Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics is published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vassallo, the managing editor of the series here at Elsevier, and for our 15th podcast, we'll focus on the October 2024 issue on management of pancreatic cancer. As the editor writes in his preface, the evolution in the treatment of pancreatic cancers has been marked by slow but steady progress. From the basic understanding of tumor biology to management of patients with advanced disease, incremental progress has been made at every level. Here to discuss this progress with 4 articles out of 14 from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the pancreatic cancer issue, Dr. Samir Patel, associate professor in the Division of Surgical Oncology at the University of Cincinnati College of Medicine in Cincinnati, Ohio. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John. Good morning, Samir. Thanks again for joining us for this meeting and for all the work that you and your colleagues did on this issue. It's, as always, I can't recommend highly enough to trainees and practicing surgeons alike to read through this material. We're going to have a conversation today about 4 of the articles from the issue, but this is one you really have to read through and take your time, because there's a lot of fantastic information picked in it, and I think that people will benefit from it. Certainly, if somebody were meeting one of us as a boards examiner, this is the kind of information you want to have in your back pocket. But I thought we'd start off today with the chapter that we have on neoadjuvant and adjuvant therapy for pancreatic ductal adenocarcinoma. And this is from Doctors Johnson, McClelland, and Ahmad. And I think that sometimes the conversations we have on these articles sort of follow a little more along with the text, and sometimes we have to sort of take a more overview standpoint, for the listeners. So I think this one's one where we're going to be a little more in the overview, because there's a lot of packed data and text that's really worth reading. But let's just start off with some basics. We sort of break pancreatic cancer down kind of quasi-anatomically these days into things we believe to be resectable, things we think are borderline, and things we think are locally advanced. And while I would say that it's more of an analog scale than a digital scale between these, but give us your rundown on how you break out these concepts, and what do you use for imaging and whatever else to make your initial assessment.
Thanks, John and Dr. Martin, for having me today, and it's really a privilege to be part of this great series. You hit the nail on the head when you said, unfortunately, really the best that we have is good cross-sectional imaging to at least put these patients into really 4 categories. The resectable, the borderline, locally advanced, and even those can be broken down into kind of the low risk, high risk, and then finally the metastatic. And the best modalities we have are good cross-sectional imaging. So for us, it really is using either CT or MR, and it's somewhat institutional specific, but at least we want a few things, cross-sectional imaging, at least from CT standpoint, thin slices so we can really pick up anatomic detail. We want to make sure contrast that's given is given in at least in multiple time periods, so an arterial, a true venous, and then a delayed venous, so we can really have certain lesions show up a bit more clearly. And then having good reconstructions. So the better or the thinner quality our initial axial phases are, the better they can do reconstructions in the coronal and sagittal, so we can really get a good sense of what that anatomy looks like. And that really has been kind of the mainstay of how we categorize these patients. But I think we also need to realize that there are many more components to it. Looking at tumor biology, and I know we're going to probably spend some time discussing that as well, where things like CA19-9, which has kind of been the backbone of how we assess that, are used in addition to now potentially using other molecular information. And finally, we have to take a step back and look at the patients themselves, because we know that physiologically each patient is very, very different. And if you add or look at any of those 4 combinations of patients anatomically, you add on their biologic profile and genetic profile, and then put them into individual physiologies, you can see that it's not just simply 4 categories or more, it's just that number grows exponentially.
Yeah, and I think that brings up a good point. I don't know that we've ever talked about it on the podcast before, but this is probably a good time to bring it up. And it's something I used to emphasize with residents and trainees and junior staff people when I was teaching people to do this kind of work. But people often confuse and interchangeably use the terms resectable and operable. And just for the average listener out there, you shouldn't. To me, resectability always refers to the tumor. We look at it, no matter what kind of tumor you're thinking about, they all have a criteria for resectability or unresectability. But operability refers to the patient. Once you come up with a plan, is the patient up for it or not? And I think that piece goes missing, and rightfully so. I mean, nobody's deliberately trying to obfuscate the data, but you can't necessarily factor in all the operability criteria when you're coming up with staging systems or classification systems. It would the permutations are endless. But that's for those listening who are new to the game, that's a concept to drill into your head early, as was mentioned by Samir, because that's what really helps you make the final decision. So let's talk a little bit about. I mean, some things about surgery change a lot, and some things stay kind of the same. And one of the things that stayed kind of the same for the last, I don't know, 50, 60, 70 years is that we really have local and regional treatment and we have systemic treatment. And now what we have to offer in those categories has changed a lot. But I think in the world of periampullary neoplasms, body, tail, pancreas neoplasm, we're going to talk about that divide a little later too, I hope, is we've got operative management that comes in a number of different forms for head lesions or body lesions. And we've got radiation therapy that comes in a bit of forms too. And then we've got all the systemic options, which are now becoming a lot more diverse than they used to be. So I think for the most part, if we're confining our discussion more to the periampullary side of things, the head and neck lesions, we're pretty much looking at pancreaticoduodenectomy with some form of reconstruction. Interestingly enough, I got a text from one of my former partners and former trainees, because she's now a program director of a program I used to direct, and she got into a debate with one of her residents over who did the first pancreatic resection, and they had both argued, and neither one of them was right, really. We had to break down why, because the operation called the Whipple, that particular version, the pancreaticoduodenectomy with hemigastrectomy and pancreatic reconstruction, Whipple never did, not even once. Of the 35 operations he did, he never did that the operation that has his name on it. So I would encourage the listeners to scrap the eponyms and think about the anatomic parts of what you're doing, because that part's indisputable. So you'll get in less trouble if you just stick to the anatomy. But in terms of combining therapy, which I think is where we've been for the past 40 years, give or take, the issue is always, we started off with surgery alone is the answer to everything. That, the kind of the chance to cut was a chance to cure. And the quicker you got to it, the better off things were. I never really bought into that. I always thought that this was a systemic disease. We had reasons, and Rossi and Blake Cady, my mentors, were sort of helped lead me in that way. But now we're into sort of the combined thing. So let's talk about, particularly with this article, we're talking about adding in medical therapy and whether to go up front or after or both. So, we sort of follow a little bit the model of rectal cancer, maybe esophageal cancer, depends which end you like to start from. So give me your thoughts on, let's just, we started off with the Gitzig trial, which now seems like ancient memory. And we're now really working with more FOLFIRINOX and gemcitabine and paclitaxel. But, just give me through your thinking on where you are on neoadjuvant versus adjuvant and how you got there.
Yeah, that's a great question. And, as you said, Jitsi kind of started it all, back in the 80s. And really, those first series of studies were really looking at things in the adjuvant standpoint, because as you said, if anatomically these patients are able to undergo surgery and get through it, then that's their opportunity to then get their additional systemic therapy as opposed to kind of changing the sequencing order. And it was really those original adjuvant studies going back to SPAC, the ORTC, the CONCO studies that looked at what happens if we give radiation or 5FU with radiation afterwards. And then we realized that gemcitabine was better than at least observation, and then gemcitabine came into the mix. And we've kind of been slowly building on that. And I think really the biggest studies that have come out the last kind of 5, 10 years have really been ones such as the Produce 24 study, which has really kind of set the stage as far as what are the best outcomes as far as overall survival that we can see in patients that we put on trial. So this was a French study that looked at patients that underwent surgery and then received either adjuvant gemcitabine, which was really standard of care, or a newer multi-drug regimen, which was modified FOLFIRINOX. And they found that the group that received that modified FOLFIRINOX had a median survival of over 54 months, kind of a number that we oftentimes really don't see in studies. And this kind of really shook things a little bit because it's suggested that perhaps these adjuvant approaches are better, at least in patients that had resectable disease compared to using the neoadjuvant approach. And in the neoadjuvant arena, I think people are aware that it can be hard for patients to undergo surgery, recover from it, and then go on and receive systemic therapy, which oftentimes can be associated with pretty significant toxicities, especially when we talk about adding on multiple drugs, not just a single agent. And so the rationale for neoadjuvant really came is that if we really truly believe that neoadjuvant therapy is really important because pancreas cancer really tends to be a systemic disease, give it to them before surgery. That way we know they've gotten a big part of their treatment. They can then undergo surgery, and still in the best of hands, complications can arise. And then if they're able to recover and they get additional treatment afterwards, we still haven't lost that window to give them a really big part of their treatment. And when we look at some of the neoadjuvant studies and the survival associated with them, we found that those numbers just didn't quite add up. We weren't seeing these 54 or 50 plus month survivals. And so that really caused a lot of controversy. But I think we have to take a step back and realize that if you look at Produce 24 in the adjuvant setting, those patients all had surgery, they recovered, they then were strong enough physiologically to receive systemic therapy. And then on top of that, they threw in tumor biology because they wanted those patients CA 19-9 to be a reasonable level, and it was less than 180 or so. And in the best of the best, those group patients actually had this amazing survival. But if you look at the other arm, which was also pretty striking, the gemcitabine single agent arm, which was standard of care, and I think most everyone agrees is kind of an older systemic regimen, that group survival was 35 months, which was still quite remarkable. And if you look at kind of the sequence of trials over time where gemcitabine has been used as one of the arms, we see that arm has improved from 12 months to 20 months to 25 months, and it's progressively gotten better. And I think it's a reflection of better patient selection. And so that's kind of where we're at in the at least adjuvant arena. Now, the neoadjuvant arena, I think most people still agree that it is really the way people have shifted their care and their management and their thinking, and that we still agree that these failures or these metastatic lesions that we see soon after surgeries are still present. And it is a reason why we oftentimes think of giving systemic therapy beforehand. And there's several trials that kind of talk about that.
Yeah, and I think you bring up possibly the overarching theme to this entire conversation, if not the entire issue, is we start to sub-select people for these reports based on the way we address the problem. And that's not wrong or bad, but it's sort of like a bunch of people running on a trampoline. Every time somebody takes a step, it changes the landscape for everybody else in the trampoline. And if you believe that it's a systemic disease and people die from systemic failure, then the general concept would be get the systemic therapy going pronto. And then you end up sub-selecting the people who become candidates for an operation later. And those who don't do well with that don't get an operation, or maybe they get an operation in bad circumstances and they don't do that well, so they get selected out. Conversely, if you take the people you operate on up front, those who had probably a more favorable biologic process become candidates to get more or less challenging chemotherapy regimens, plus or minus radiation, and then they do better. So we bias the studies out a lot based just upon how we frame the question we're trying to look at, and that's okay. I mean, that's the limitations of dealing with humans. You can't simultaneously take multiple paths at the same time, no matter how hard you try. But I think you're right. I think, the idea being is that I think we've all felt that at the end of the day, the problem with pancreatic ductal adenocarcinoma in specific is that it is a systemic disease by the time you know it's there, and your ability to deal with it on that level, or its ability to respond to what we have up in mind, is going to determine the long-term outcomes. And the rest of the stuff is sort of, rearranging the tiles on the board. But that sort of brings us into the next chapter. I think we'll morph into this a little bit. There's one on radiation therapy for pancreatic ductal adenocarcinoma by Keltner, Nelson, and Carafa. And I think it's really the same issue written from a narrower lens, which is, are you going to give radiation at all? And if so, are you going to give it up front and after? I mean, we certainly went through a phase where we weren't radiating anybody, then we were radiating everybody, usually afterwards. And then radiation sort of fell out of favor, and now it's back in some other aspects. So let's start with your thoughts on in terms of increasing local regional control. Where do you think we are with radiation? And we'll start with, external beam or SBRT for openers, and not get into brachytherapy necessarily.
Yeah, and radiation therapy, still is a question that is kind of up on everyone's minds as far as kind of what to do with it. The assumption being that, local control is really important, because if radiation can be used to treat local nodal basins, then we will have lower rates of potentially node-positive disease, and those patients will have better outcomes. If we use radiation, we have better R0 or margin negative resections. Those patients will have better outcomes. And several of the studies that have occurred have really looked at, what happens if we do radiation? Do we see that? And the answer is yes. We tend to see higher rates of margin negative resection. Do we see higher rates of node negative disease? Similarly, we're seeing that. But does it translate to better overall survival? Because again, we're going back to the theme of pancreas cancer really just being a systemic disease. And sequentially, the earlier studies, did show that if we use chemo with radiation, those patients have good outcomes. But when we really try to parse it out with chemo alone versus adding radiation, do we start seeing difference? And that question is, still really up for debate. The original PREOPANC studies, which looked at gem with radiation and some chemotherapy afterwards, really found that there were no differences in the original PREOPANC study. They then put out an additional kind of updated outcome several years later, and they found that there was an improvement in survival, but only in the group that had borderline resectable. So those patients where our margin positive rate is going to be higher because there's a greater degree of vascular involvement. The next study that kind of came out that the Europeans did was a PREOPANC-2 study, which they looked at chemo. In this case, they used FOLFIRINOX versus that same radiation with gemcitabine. And they essentially found that the outcomes were the same as far as their median survival of over 20 months. And so in that realm of these resectable and even these borderline resectable patients, is radiation helping? And the short answer seems to be no. But I think it may be that, one, the study isn't completely out yet for PREOPANC-2, so we don't quite know. Secondly, it may be like PREOPANC-1, where we need more time to see how those data and how those patients' outcomes will really kind of parse out. And then even in the advanced setting, when we look at some of the locally advanced diseases, we're starting to see these head-to-head trials that look at chemotherapy versus adding chemo with radiation. And the radiation doesn't seem to be really improving patients' overall survival. And it kind of again goes back to what is radiation really doing? And I think the other component to this that makes things a little bit more tricky is that the types of radiation used are different between some of these studies. The ones where we see positive signals tend to be more the conventional 5.5 weeks. But now, as you can imagine, patients don't want to go through that long a time period of radiation. They rather get a much shorter course, and that usually translates to higher doses. And the way those higher doses kill cells are a bit different, and that can impact things as well, not only surgically, but even from a long-term outcome standpoint. And so if we look at patient selection, selection really comes down to time. I think if we give patients sufficient amount of time from when we see them, time is really the ultimate test to see, are these patients going to develop metastases, or what are their outcomes going to be? With longer courses, we have more time. So that is a pretty important component to it. And so unfortunately, in most of these studies, the radiation arm is not quite panning out the way we expected it to. Not necessarily in a bad way, but I think it just says that we have to use it very, very selectively. And so if we're worried about margin status, then I think radiation is appropriate. So for borderline and I think for locally advanced, that really kind of goes without saying. For resectable disease, I think we still don't quite know. And so that's really where the next series of trials are really coming into play.
Yeah, and I think, you open up, I don't know if it's Pandora's box, maybe Pandora's sister's box or something, but, so we get into the how do we measure whether or not things are doing something. And one of the things I've agonized with over my career is that overall survival, disease-free survival, there's a bunch of things we look at, and maybe they're not always the right endpoint. And because, to me, in a very simplistic view, I really struggle with the overall survival data on all of our trials, because we get into these really big numbers and you have these statistically significant changes in overall survival, and it turns out it's like a difference of like 6 weeks or something. And nobody's ever, created, including myself, like a Martin modified index of how many weeks of a good life do you get back for how many weeks of crappy time did you spend in therapy, to see if it was a net positive. Like if you spend 6 months being miserable to extend your life by 3 weeks, was that a good ROI of doing it? Those are quality of life statements, and people have studied it, but it's hard to come by. But in some respects, the role of radiation therapy may be considered an adjunct to overall survival, but it may also be considered an adjunct to making somebody resectable, because there are other gains from that. And I've always struggled with, does R0 mean the same thing in somebody who's had neoadjuvant therapy of any kind compared to somebody who has just an upfront operation? I think we went through that with rectal cancer, and I think the answer came up was that the answer is no. It doesn't. Restaging is inherently problematic compared to our original staging criteria. And I think in the last article we get to, we're going to get back to that in a way, that our staging criteria are all weird anatomic proxies that exist from the pre-knowledge of DNA to give some sense of what the biological behavior of a tumor will be. And your comment strikes me is that time is also a weird proxy for biological behavior, because biological behavior multiplied by time yields outcome. And so the longer people have, the more it tells you about the specific actions of whatever tumor they may be harboring. And I never written about that, but probably I should have at some point. You will, for the both of us, hopefully one day. But I think that's the thing. So, so if we look at radiation outside of the survival piece, and we look at it in terms of let's call it an adjunct to resection, just for lack of a better term, what are your thoughts on how much it improves your ability to take somebody that you think is borderline? Because as we talked about earlier, the imaging doesn't always tell you exactly what you're going to find. You're really taking static shadows of something that aren't being moved, and then we go around and get our hands in there and start trying to move things and realize that's a little more stuck than I thought, or what have you. So on one hand, it generally, to me, in people who have a response, obviously, it probably makes somebody who looked borderline become more resectable. But it also makes things stickier, and it may or may make things harder to put things back together. And the resection in these cases kills the surgeon, and the reconstruction kills the patient. So, so what are your thoughts on radiation around the technical aspects of resectability versus reconstruction?
Yeah, it's a great point. I will say that, the radiation does make things challenging. And that's why it's so important to really have a good multidisciplinary team around you where the radiation oncologists are very aware of, what they want to target, what they want to hit, that tumor vessel interface, making sure that the right amount of doses are given and, they don't necessarily completely blast the field and make it so if we have to do a pretty significant venous resection reconstruction or do a divestment around the artery, that we're not really injuring those vessels or making them prone to just have more perioperative complications, intraoperative complications, and things like that. But I think unfortunately the radiation oncologists have gotten pretty good at being able to do that where, even with higher doses, they can really narrow in and target those areas so that it can make it so that perineural plexus around the SMA that did have tumor is now turned into kind of that scar where, we can take it off. But yes, there are definitely examples and situations where, if folks aren't that familiar from radiation oncology standpoint, they can really injure those tissues, make things a lot more challenging. I think we also have to think that, local recurrence is a real problem, and there are probably 20 to 30% of patients that have kind of this local only disease where if it does come back, it leads to just long-term poor quality of life issues with GIs, management and things. I think the Hopkins group did a really nice job of kind of showing that, these patients do exist. I will say from another technical standpoint is, radiation doesn't necessarily a bad thing, especially when, you're trying to sew to a small gland or a small duct with a really soft gland. That radiation does kind of thicken things up a little bit. And as we know, pancreas leaks and postoperative pancreas fistulas are the bane of pancreas surgery. And so anything we can do to thicken that up, I will take. But yes, I think, does every patient need to get radiation? I think, the answer is probably not the case. But I think there are definitely groups of patients that selectively should get it. I think borderline locally advanced are ones. And then even some of the ones where they're questionable, where we think they're resectable, may be a role for that. We just haven't quite figured it out yet.
No, I'm with you. And, I was around in the days when we were doing intraoperative radiation therapy on all these people, and that is a song and dance I hope we never go back to. That's just hopefully it's of historical interest, but wheeling people around corridors with sterile drapes over lucite cones to bring them to when you didn't have the combined rooms, that was just the craziest thing ever. But we don't do that so much anymore. So let's continue this into there's another article in the book called The Role of Surgery for Oligometastatic Pancreatic Ductal Adenocarcinoma by Hewitt and Chris Wolfgang. And I think it really brings us into continues with this concept that this is just a continuum of disease. And so this one, to me, redirects the question to how far away do you want to spread your local and regional therapy away from the primary target in the hopes of addressing a systemic disease? And it's not unique to pancreas cancer, obviously. But I think one thing we all agree on, or I think we do, is that people who have M1 disease do less well than people who don't. I mean, that's just kind of what it is. And so with the primary organs being liver, lung, and peritoneum for what this chapter discusses, and I think we have to maybe put peritoneum in italics compared to the other two, but that's okay. But give me your thoughts on what exactly defines oligometastatic disease. Is it amount? Is it location? Do you have some number when it goes from oligometastatic to semi-oligometastatic to widely metastatic? I mean, how do you divide those up?
Yeah, I think you are completely spot on. The problem is we don't know what that definition is and what it means. And I think even in the studies that talk about good outcomes with resection, of oligometastatic disease. It's in quotes because each of these studies defines it very, very differently. Um, you know, Theoretically, we would say that it is a limited quantity or burden of disease, but how do we define that? Does that mean that these patients have CA19-9s in the 100s with a single lesion in the liver? Or is it a single lesion in the liver with a CA19-9 of, 8,000? Those are very different, even though imaging-wise we may see limited quantity. It's hard to justify that being truly oligometastatic. And then I think it comes down to location as well. The way patients' outcomes are if they have this limited disease in the lung only versus the liver versus the peritoneum are very different beasts kind of in and of itself. And so, how and location, as well as just the biologic component to it, or how we're able to assess biology by at least tumor markers, circulating cells or circulating tumors, circulating DNA, circulating RNA, however we kind of package it, those all come into play, but how each individual component contributes to it, I think is yet to be determined.
Yeah, I think you're right, and I mean, I know you're right. You're right, but where I think we've all been struggling with this for a long time goes back to what we just talked about briefly ago. Is we try to define neoplastic disease in terms of the things we can see. And we're working our way towards defining it in terms of the way it behaves. And we're just sort of in the middle of the road on that. I mean, it feels to me like any minute, it seems like we're going to get to a point where we can do some fairly non-invasive sampling of things and have a really good sense of what tumors are going to do. But I've been saying that for like, I don't know, 30 years, a long time. I mean, my background in genetics before I got into surgery, I think was more optimistic. I mean, but there's people are certainly getting there. But, for this one in particular, I think we get into the conundrum of what do we know about, what does negative information tell us? And I think when we see MET someplace, whether it's we see an anatomic lesion on some imaging, or we do a functional study and we see evidence of activity of cells, FGD PET probably being at the top of the list, versus we look for markers that there's increased activity of cells. And you mentioned a batch of them, CA19-9, circulating tumor DNA, circulating tumor cells, all these things. We certainly get to a point where we have these proxies for things, but I don't know what it means to have lung lesions from pancreatic cancer and have nothing in the liver, and whether I believe there's really nothing somewhere else. Is that ever worry you, or am I the only one?
It's what scares me more is what we can't see and our inability yet to be able to detect it. And I think circulating cells, DNA, RNA, exosomes, that is starting to try to answer that question. But as of yet, it is still a concern in that it's a bit naive to think that there is only that single lesion in the lung and nothing else anywhere else, because we know that's not the case. And there's been a few nice studies too. Even Dr. Wolfgang, who wrote this chapter, he conducted the cluster study, which was a longitudinal study where they actually collected blood from patients that had resectable or localized disease, and they found that even these patients with anatomically resectable disease, over 95% of them had these circulating tumor cells around. And so if that is a reflection of our earliest stages or our earliest anatomic proportion of patients, and they have these cells, then the patients that have these lung lesions, liver lesions, peritoneal lesions, that's only going to go up exponentially.
Yeah, I mean, when I was young, even younger than you probably, and Ricardo and I were starting to tackle this, and we were coming up with some new techniques of looking at tissue, our pathology colleagues were, we found that 70% of the people that we thought had node negative disease, if you did more sophisticated analysis on the nodes, you found tumor cells in them, but they would have been N0 by our usual criteria. And that just kind of led us to think that that's remarkable, because that's about the number of people who fail when you think you've got an R0 resection. So there might be something to correlate. I'm not sure it really correlates head to head. But I think one of the things the authors do well in this article, I mean, the whole article is a great article, but this concept of multi-omics. I mean, I think we're in this meta-analysis of we've got a whole bunch of information and we don't really know how to put it together yet. But this is how you figure it out. And as you say, Wolfgang has, he's worked with us before and done a great job on the series, and just a super smart guy. And they're working their way through it. But I think in terms of whether we want to call it precision medicine or directed medicine or tumor specific medicine or whatever we want to, would be the phrase of the day, that this is what's leading us to get away from these anatomic criteria and to get more into understanding the genetic propensity of a neoplastic cell to behave a given way. And some of it's going to come down into, and when we get into the final article, I think we're going to talk a little more about clonal expansion. But I think a couple of the things they brought up in this really resonated with me from problems we had in the past. I mean, in particular, that the tumor biology of body and tail lesions appears to be different than the tumor biology of head and neck lesions. I think we all had an intuitive sense of that. And certainly Rossi and I wrote early in the game in terms of our algorithms without any real reason to believe it, that when you had body and tail lesions, you needed to treat them differently because their propensity to have metastatic disease you didn't know about was much higher. I think these guys have narrowed it down a bit more as to why. That there's more likelihood of having metastatic disease and more likelihood of having peritoneal disease. Do you think it's more a function of just the cells behave differently out there? Do you think it's more of a function that body and tail lesions have more time to misbehave before they present symptoms in most people?
Yeah, I think it's definitely a bit of both. I think the time component again comes into play in that, a small lesion in the head that causes obstructive jaundice prompts evaluation, and there's a chance of us being able to pick it up sooner in time. Whereas body tail may go a little bit longer, and that little bit of time longer translates to more time for diffuse disease to kind of rear its ugly head or kind of be present. The other is, heterogeneity within the genomic and molecular profile, and as you kind of mentioned in the next article, kind of discuss a little bit more about that. But, I think is to say that, no tumors are the same. Even within a solitary lesion, there are a cluster of cells that are very, very different. And not just a cancer cell, but also the environment in which they sit in, the tumor microenvironment. And so I think biologically they're very different. We know embryologically, the head as well as the body and the tail, there are differences in the cells that they kind of originate from. And so that sometimes may play a role in impact. I think we're just starting to kind of delve into that whole aspect of the molecular aspect to understand how that is contributing and impacting the stage and the eventual outcomes of these patients and what the behavior biology of these tumors will be.
No, I think you're right, and I think it's helping us to narrow in on where to look and how to change our assessment of what's working. Because I don't think when we look at these historically, as I said, we talked about a little bit earlier, overall survival, it's a great marker from the standpoint that you generally know who's alive and dead. So it's a little hard to fake. But from another standpoint, it doesn't really give you a lot of information about how much impact you had when there is tumor heterogeneity. I mean, you might have had great impact on some of the tumor cells and no impact on the rest, and then whether that becomes important. I think on a more philosophical level, we certainly have trended over the past 40, 50 years to the idea that neoplastic disease, we're willing to consider a chronic disease instead of an acute one. And so the role of operating for oligometastatic disease always makes sense in the standpoint that if you think it's chronic, as long as you can get your risk benefit equation to something normal, and certainly as the authors point out, videoscopic techniques, percutaneous techniques, robotic techniques have made it a lot less morbid for the patient to have oligometastatic disease treated specifically. And we'll probably get more ground on that as time goes by, but I think they are on to something there. And we'll see how it bears out. But in the time we have left, the last article that you picked to discuss is the updates in molecular profiling of pancreatic ductal adenocarcinoma by doctors Lee and Ye. And I think it really, so here we're getting into the more cerebral side of the surgical world. I mean, not that the rest hasn't been, but I mean, we're really looking at subtypes by mutation. So I would encourage the reader, as we talked about earlier, to read this particular part, because we couldn't just sit here and recite every mutation type they have. They're good to know. A lot of them are KRAS based, but there's several subtypes within that. But, I think that, basically we're looking at trying to categorize these by either microarray or RNA sequencing or something. So what do you use, or what do you use to try to do your subtype analysis of these tumors?
Yeah, that's a great question. And, the authors do a great job of summarizing just decades of work and how they really try to simplify how this can be used. In our clinical practice, we do have a genomics core that takes coordinated biopsy samples or resected surgical specimens and then performs called a multiplex and thorough evaluation of genetic profile of these patients. What they're referring to in these chapters as far as kind of breaking the genomic profile into two categories, these basal and classical subtypes that the Moffitt group and Zhenjian Ye really have pioneered, we haven't quite done yet. But I think the authors really talk about how they are going about doing that, and can it be done in a high throughput fashion at any center that has a CLIA approved lab. And their work really suggests that that is possible, and it is a reasonable way to kind of evaluate some of these tumors. But in clinical practice, as kind of you asked, what we are doing is really using our genomic profile to look for actionable potential mutations. Now, for patients with metastatic or advanced disease or locally advanced disease that are not surgical candidates, we do that for all of those patients because we're looking for these 1 to 2% mutations, whether it's BRCA, KRAS, which we know that the vast majority of pancreas cancers have, to try to identify if there are appropriate clinical trials we can put them on. For patients that are resectable candidates, we similarly do that to provide, at least right now, prognostic information to know, what are the chances of recurrence if we are able to identify signatures that say they are, for instance, this basal type or this more aggressive phenotype compared to the other patient population. And similarly, we know the risk of them developing metastatic disease is pretty high down the road. And so those information can then be used to identify future clinical trials for these patients.
Yeah, and I think, again, for the readers, I would encourage them to look through the descriptions of the different series, but this classical exocrine basal type metamorphosis, or polymorphosis is probably a better word, quasi-mesenchymal type tumors. This is, I think, at the heart of the whole thing. It's at the heart of everything we've been talking about for the last 45 minutes or so, that we have these therapies that are directed at some neoplastic cell, something that's lost its cell cycle control. And we probably have activity against part of whatever's gone mental from a genetic standpoint. And we don't against the rest. And the question is whatever's left behind, does that develop an ability to grow and get out of control in such a way that it hurts a patient? I mean, it's a childlike question, but it's kind of where things are. And I think that's really what we're up against. It's this, all cancer is some form of de-differentiation, right? It's becoming somehow more primitive. And it's just turning on and turning off parts of the DNA blueprint that were supposed to be left alone, in the most simplistic view. And I think that there are descriptions about going through these and looking at tumors that are more pure in one version or the next. And then the tumors that are mixed are in that, category where they've kind of got both going on. And the numbers, there are different series they put in there and slightly different terminology, but the themes come out the same. But I think that this is where we're at, that the concept of either tumor resistance probably has nothing to do with the cells that we were treating becoming resistant. It probably has to do with changing the ratios of something with polyclonal expansion. And then obviously the question that comes out of that is, can we say much about metastatic disease from looking at primaries, or not? So what do you think about that?
Yeah, I mean, I think it is still a challenge to be able to do that very thing. We assume that whatever lesions come back that recur are going to be biologically, genetically, phenotypically the same as a primary, and that's not the case. Even in the solitary tumor that we resect, we know there's heterogeneity within it. Even the profile of that tumor pre-treatment, pre-neoadjuvant therapy versus post-therapy are very, very different. The ones that respond will ideally be the ones that die, but the ones that don't, or the ones that are left behind, have changed or have the ability to change. And I think the authors do, from their kind of expansive work, show that there is this switch where cells are pliable enough to be able to switch from one phenotype to another. And it makes sense because cancer is always going to find a way to kind of survive. And that is innately the challenge in the treatment of it. And the reason why even these new and great actionable drugs that are starting to come out have still very high resistance rates. I think, the biggest one is KRAS drugs, the undruggable drug, which now over the last, decade is not the case. And, it's really thinking outside the box of finding drugs that can bind to KRAS and knock it out of commission. And it's not just one particular variant with a particular G12 mutation, but now there are even pan-RAS inhibitors that can just hit every version, even the wild type versions. But still, even in those groups of patients that have a response, there are still failures and there are non-responders, and there are patients that initially respond, but then they develop resistance. And so that's just opening up another whole can of worms. It's a nature of, it will never just be one particular phenotype or genetic background that we can assign to a tumor for a patient that will always be consistent. We have to think that it's going to change, and we have to be ready to anticipate that change. And I think that's where the next, hopefully, future of kind of treatments and thinking outside the box will kind of come into play.
Yeah, I think you're right. And I mean, hazard to venture guess, as Yogi Berra said, of all the things to predict, the future is the hardest. But, if you to me, if you look at where we're going with nanotechnology and our ability to rapidly evaluate small amounts of anything, that our ability to get information about metastatic disease or even polymorphic local regional disease is probably going to derive from some way of getting, for lack of a better term, spilled products from those cells that we can collect from somewhere else. So blood would probably be the most logical candidate. And you go back to the circulating tumor cells and circulating tumor DNA and CA19-9 and whatever other markers we're going to come up with. I can envision a day where if we can analyze that stuff quickly enough and in real time enough, that people will get into, okay, for now you go on chemo regimen A and you get treated with this, and in 3 months we recheck you and we see that we've eliminated these pieces of this, but now your predominant cell type that's out misbehaving is something different, so you now get chemo regimen B. And who knows, maybe we'll get into some gene editing at some point and really throw in some of the demons of rearranging genetic problems. And I think that probably is where it goes. But I think that's going to be the thing, is it's going to be this constant retesting and recalibrating new therapies for people as they progress through disease. And maybe people will progress through common pathways, but if somebody forced me to take a wager, I'm going to wager that people are going to progress on non-common pathways. And that's probably why we don't see uniform responses to the things we do. But I mean, I don't know. Do you see another way out of this that I'm missing? Hopefully you do.
Well, I think that is definitely a big part of it, and that, it is going to be multiple different things that we need to kind of reassess and constantly reassess. And essentially what you described is an adaptive clinical trial. And fortunately, there are several that are out there kind of using this basal classical subtype as one way to kind of see, is there a switch? And if there is a switch that's detectable by peripheral blood evaluations or rebiopsies, do we switch to a different regimen? CA19-9 is one of those things that are being checked where patients start on, say, FOLFIRINOX, then they get a CA19-9 evaluation. If it's stable and going down, you kind of stay the course. But if it goes up or it doesn't necessarily go down, then you consider switching to another regimen like gemcitabine or Abraxane. And so those clinical trials and kind of thinking that way are where the future should be headed. And I think it's not just those simple things, but then taking into account every other component, like patient physiology, not only just anatomy, which we've been doing, but just other ways to assess that.
Great. Well, I think we could go on like this for a long time, and I'd love to, but we're kind of coming up on the hour. And again, I can't thank you enough for you and what all your co-authors did to put this together for people. We didn't get to the other chapters, but I certainly encourage the readers and the listeners of this to go look at them as well, because you can dive into all of them. And I'm really glad there are people like you out there that are going to keep at this after I call it quits. So thanks again for doing what you do and for putting this issue together for us and for taking time this morning. I really appreciate it.
Thank you again so much for having me. And again, I want to thank all the authors that helped create this phenomenal issue. It's really a great read and just an all-encompassing, very densely packed, but still all-encompassing kind of snapshot of where we're at in pancreas cancer management. I hope that in the near future, you'll need another issue done very quickly, because all of these information will be outdated very, very soon.
That's always the way it works. That's why we come back to these topics with a certain frequency, but the surgical clinics will march on, and I agree with you. And if you go back to the very first issue of the clinics back over 100 years ago now, John Deaver from Philadelphia was the sort of the lead guy on that issue back when they used to go out by city. And they were writing about pancreas stuff in that issue, and that was like 1921 or something like that. So, yeah, I'm confident the clinic series is going to come back to this, and people will see the stepwise progression. But you've certainly built a big platform for people to march their way forward to how to understand this. I think this issue is going to be a pivotal issue in the total arc of the series. You know, for the century-long time, you and your colleagues have really given a ladder for people to increase their understanding of this disease on another level. So again, we appreciate it.
Thank you again.
Thank you for joining us for this Surgical Clinics podcast devoted to management of pancreatic cancer. The 4 articles discussed, as well as 10 others, are in the October 2024 issue, Volume 104, Number 5. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcast on most major audio streaming platforms, including Apple and YouTube. Visit theclinics.com for more details. Thanks for listening.